Now we want to talk about disaster preparedness. Primarily what we focus with are what's called a mass casualty respiratory failure. And this is some type of an event that results in patients needing mechanical ventilation or some other type of respiratory care in excess of the space to care for them and the devices to provide that support. Now you have to realize that the threat can come from anywhere. It could be a natural disaster, it could be terrorism, it could be a biological outbreak, H1N1, SARS, MERS, Ebola, H7N9, polio, H5N1, COVID-19. These and more are listed in your objectives. Most therapists will be involved inside the hospital instead of at the actual scene of the casualty. But we are going to talk in the next video about what happens at the scene of the casualty so that you have an understanding of why things are done the way they are, so when the patients are coming to you, you have an understanding. Now, the Department of Homeland Security is who is in charge of dealing with national disasters. And they have what's called National Planning Guidelines. And these guidelines coordinate and prioritize emergency preparedness at all levels. Currently, there are 15 national planning scenarios, and 2/3 of them can result in mass casualty respiratory failure events. But don't forget, there are small disasters that are a probability. And I talk about Penn State. I used to work at the hospital next to Beaver Stadium in State College. Think about the fact that when there is a home football game, Beaver Stadium is the third most populated place in Pennsylvania. What if half of that stadium collapsed? That's not a national disaster. What was more likely for us was Penn State would win or Penn State would lose, and everybody would get drunk, and then they would all show up in our emergency room at the same time. All we needed on top of that was a motor vehicle accident, and we were exceeding our capability to take care of patients. So we were constantly activating our disaster protocols when I worked there. Now we follow what we call the disaster management cycle. This cycle helps us to learn and better prepare. So you see on the right where we have an event. Part of Beaver Stadium collapses. We move into the emergency part, which is the response. So we're going to be in the throes of everything, dealing with patients, dealing with whatever's coming through the door. Once those patients have been seen and handled, then we go through restoration, and that is recovery. Now people can catch their breath, catch up on things that need to be done. Then we move into the next phase called reconstruction. This is mitigation. What didn't work? What could we have done better? What did work and what worked really well? And how do we fix those things? During that, we have what we call capacity building. This is where we try to make sure we don't get caught again making the same mistakes. And while we're doing that, we move into pre-impact, which is preparation. We are preparing for the next disaster. So this is a continual cycle. And we are always in the preparation phase until there is an event. We can apply this to patient care as well, not just disasters. There are three main classifications of a national disaster. There are traumatic injuries, there are chemical weapons, and there are epidemics and febrile respiratory illnesses. So COVID-19 was an example of that. For any national disaster, there are four things that you need to keep in mind. Actually, in any disaster, you need to keep these in mind. What is the expected number of victims? What is the time from injury to the need for ventilation? What is the pathophysiology? Is it a disease? Is it a trauma? What exactly are most of these people going to have? And what is the geographic area affected? If we were to have something happen here in Harrisburg, there are multiple hospitals that can absorb that type of an impact. But when I worked in Penn State, there is only one hospital in Center County. So anything that happened, that hospital has to take all of it. So we need to work on planning for mass casualty respiratory failure. That means staffing. Who gets called in? Who doesn't get called in? My favorite thing is they would call the administrators to come in. The vice president doesn't know how to do patient care, so him standing there in the middle of the emergency room was just getting in my way. So who really needs to be there? Do we have personal protective equipment for everybody? How much oxygen do we have? And is it going to get us through the crisis? How many disposables do we have? Not just respiratory disposables. And how many ventilators do we have? Remember, nothing lasts forever. Inadequate stocking or purchasing can mean that you don't have the needed supplies when you are in the middle of the crisis. Staffing is probably one of the biggest. Most hospitals are not staffed to handle disasters. So we don't make every person work every day just in case something happens. So somebody is going to be having to call people to get them to come in. In a mass casualty respiratory failure, non-respiratory therapists may need to be used for some tasks. So we may have people using manual resuscitators to bag people, to ventilate them. In a non-mass casualty respiratory failure disaster, you as the therapist may be called upon to do tasks that are outside of your normal scope of practice because we need hands and you have medical knowledge and training. The biggest thing here is remember teamwork. We are all pitching in, we're all getting it done to take care of the patients. Personal protective equipment. Therapists need to protect themselves. So you need to make sure that you are using and properly putting on the correct PPE. Some agents may be infectious. Some agents coming in may be caustic. And some agents coming in may be aerosolized. So you have to have an understanding of what exactly happened, what is rolling through the door. So I know how to protect myself because I'm no good to anybody if I'm now one of the victims. Many healthcare workers get infected during these outbreaks because either lack of proper use of PPE, so either lack of it being available, or people are not putting it on correctly. One topic that we don't usually discuss, but it's very important to note, is supply of drugs. Hospitals and pre-hospital providers can run low on various drugs needed to care for these patients correctly. There is not an endless supply of epinephrine in that hospital. So we need to make sure that we are accessing other resources to get the drugs that we need in times of disaster. Now, one of the big words is triage. We do triage sometimes in the hospital with our patients. We maybe have 3 or 4 things happening at one time that need our attention. Well, we can only be one place at one time. And so we have to be able to look at who do we have on the list and who cannot wait. And even sometimes people who cannot wait, we have to deal with. So one of the hardest parts outside of the hospital, as well as inside the hospital during a disaster, is that patients will die and you will not be caring for them. If I have 4 patients who need mechanical ventilation and I only have 1 mechanical ventilator, then that means only 3 of them will not be receiving that care. These are ethical dilemmas that many of you have not had to face. And throughout the program, we will be talking about medical ethics. The patient that has the most likelihood of survival is who is going to get the care. And we will discuss triage out of hospital so you're familiar with what's happening. And when the patients come through, they will have tags on them. And so you know what that means on your patient. But you have 5 people roll through the emergency room all at the same time, and they all need the same amount of care. If you're the only therapist there, you can't be everything to everyone. So in the next video, we're going to start with talking about an actual disaster situation that you may have heard of or may be familiar with, and how is that handled.